Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Shaffer, and I'm pleased to bring to you an interview with Dr. Philipp Zunke. Dr. Zunke is a physical therapist working in Salzburg, Austria. His clinical focuses are on conservative management of lower back pain, disorders in the autonomic nervous system, manual therapy, and sports physiotherapy. In addition to clinical practice, he is a lecturer at the University of Applied Sciences Physiotherapy in Salzburg, Austria, as well as a lecturer for Physio Austria, otherwise known as the Austrian Physiotherapy Association. We invited Dr. Zunke to the podcast because he was recently the primary author of a paper published in BMC Musculoskeletal Disorders titled The Effect of Manual Therapy to the Thoracic Spine on Pain-Free Grip and Sympathetic Activity in Patients with Lateral Epicondylalgia, a randomized, sample-size planned, placebo-controlled, patient-blinded, monocentric trial. As you may recall, we also recently interviewed two authors, Francisco Xavier de Araujo and Giovanni Ferreira, about a systematic review that looked at this same general topic. However, their database search was conducted a handful of years ago, and it identified gaps in the research. As a result, our conversation with Dr. Zunke will permit us to ask some additional, newer, and potentially even more advanced questions. Without any further delay, let's get to the interview. Dr. Zunke, welcome to the podcast. First, I want to know, how are you doing today, and how badly did I butcher your last name?
Well, hello, Steve. Thank you for having me here with this talk, and I really appreciate it. And I'm doing fine, and you just pronounced the name perfect.
Well, sir, that makes me very happy. I will admit not being proficient in German. However, in the modern, digital world, you can go online and find word-to-text websites, or text-to-word. So I was able to get an electronic-sounding version of your last name that apparently was reasonably accurate. But what I totally failed at is mastering the name of the university that you just acquired your PhD from. Could you tell our audience where you recently graduated from?
Yes, I graduated last year in 2019 from the Paracelsus Medical University here in Salzburg, Austria. And there was a PhD in medical sciences, so it's with 3 years.
Excellent, but you have been a physiotherapist for longer than that. Can you tell us how long you've been practicing?
Yeah, I started with the physical therapy education in 2006, and I finished in 2009, and then I started working. I changed the countries. I moved from Germany to Austria, here to beautiful Salzburg. You might know it from Sound of Music. And then I started right away my own practice. I have my own practice now since 2010.
Excellent. And since you brought up the Sound of Music, you are at the eastern side of the Alps, correct?
I would say we're on the northern sides of the Alps.
Okay. In my head, I can picture it as the northeast.
Yeah.
Perfect. And so you've been in the clinic for a while. You've obviously returned and spent time in academia. Can you tell our audience why it is that you and your collaborators became interested in this topic, and building off of that, why you designed the study the way that you did?
Yeah, sure. I've always been interested in the autonomic nervous system, as it plays a major role in both health and in disease. The autonomic nervous system is responsible for controlling all the unconscious processes in the human body, and thus for maintaining homeostasis. It's responsible for the regulation of the somatosensory, motor, visceral, neuroendocrine, and neuroimmunological functions, in response to the environment. And a disturbance in this autonomic nervous system can have a negative impact on the balance, promote the development of diseases, or even disrupt wound healing processes. So when you just think about the patients that come to our practice, for example, patients with unspecific low back pain, he just should recover within 6 weeks without specific therapy. He should just take adequate pain medication for a few days, and he's recommended to stay active. And those patients I was talking about, they usually don't come to see a physical therapist, right? The patients go and see the physical therapist if they don't heal. And I believe that the sympathetic nervous system may play an important role here, like stress reactions in work or with the family. And then you have this fight and flight reaction, and then you don't have a possible healing. Second, as a manual therapist, you go through many different trainings and educations, and they always teach you those techniques for the thoracic spine. But when you look in the literature, there's really a lack of scientific background. And Hannigan in 2015 even described the thoracic spine as the Cinderella region of the spine. I know there's just a 1-year prevalence for thoracic pain by 13%, but we do really have a high coincidence with cervical and lumbar pains up to 40%. And third, we read the review 2015 by Kingston et al., the effects of spinal mobilizations on the sympathetic nervous system. We can say that there's strong evidence for sympathetic excitation following spinal mobilizations in asymptomatic populations. But we really needed more studies investigating the sympathetic activity following spinal mobilizations in symptomatic populations. And so that's what we wanted to do, to have a look at those symptomatic populations.
So that's exactly what we would expect from a clinician who's an academic, right? You look at the background evidence, you see what it does say, what it doesn't say, and now you're trying to fill in one of those gaps. Of course, I really like that. As a clinician like you, I believe that the autonomic nervous system plays a very large role in the health of my patients. Anybody who's worked with me in a clinic recently knows it's one of the topics that I spend a lot of time paying attention to. And the next question that I have for you has to do with clinically with this patient population, right? There are many different patient populations you could have looked at. Why did you decide to look at individuals diagnosed with lateral epicondylalgia to see whether or not working on the thoracic spine would impact their symptom presentation?
We chose the epicondylalgia lateralis humeri, or the so-called tennis elbow, because it's just a common musculoskeletal disorder. The point prevalence is 1 to 3%, and it affects 40% once in a lifetime. So we were able to just get a sufficient number of patients for our trial. And second, tennis elbow is interesting because our primary outcome measure was pain, and for pain we have the pain-free grip test, and that's just a valid and reliable test for epicondylitis lateralis humeri.
Excellent. And if we could just back up for one moment, you mentioned, of course, that lateral epicondylalgia is a common diagnosis, and of course, like many outpatient physiotherapists, I see this diagnosis a lot in my clinic. But I do struggle with the idea that in the scientific literature, you can find references that say thoracic back pain is not all that common. The evidence, of course, pays a lot of attention to the low back and the neck.
Mm-hmm.
But I would be hard-pressed to think of a patient who, when I pushed on their middle back, I couldn't find painful tissue restrictions. Is this the type of thing that we're just ignoring scientifically and clinically? Or am I wrong in thinking that this is much more common than the evidence would suggest?
I really guess it's more common that the evidence suggests, because like from a clinical perspective, we know that there is a prevalence of pain and dysfunction on cervical or thoracic spine in persons with lateral elbow pain. And as you said, when the patients come to your practice, when you examine the patients with lateral epicondylalgia, you find those changes in the paravertebral connective tissue with cross links, or you find the joint restrictions. So there's really something going on. And we already know that there are changes in the thoracic spine with patients with mechanical neck pain or shoulder impingement. And we already know that when you treat those patients in the thoracic spine, they will get better.
One thing I'm thinking of right now, our listeners might be aware of, is if we go back to, I think it was, and I can just verify this right here, in episode 3 of the podcast, we interviewed a professor by the name of Dr. Brown, who had this really interesting case where they pushed on the thoracic spine and rib cage, if I remember correctly, and they resolved knee pain in I believe it was a young male patient. When I say young male, I mean early 20s. And that's the type of thing I've seen repetitively. On one level, if I'm thinking, I'm going to work on the thoracic spine and rib cage, yes, I'm going to impact the neck, the shoulder, obviously things like the elbow. But I've developed almost this mantra where, when in doubt, push on the thoracic spine and rib cage. And over the years, I have found that it's really clinically a very important area of the body. And, I'm not going to say that every time I push on the thoracic spine and rib cage, I have a magical cure for everything, because I do not. But I have been surprised by the number of times that I can work on this part of the body and make all sorts of things better, with lateral epicondylalgia just being one of the many diagnoses on that list.
Yeah, that's true. But that might be because the thoracic spine is the host for the sympathetic trunk. So the sympathetic nervous system is located between T1 and L2. And the upper thoracic spine, we're talking about T1 until T8, is connected with the upper extremity, and T8 until L2 is connected with the lower activity. So basically you have like an image of your whole body also on the thoracic spine, and that's why it might be effective. You have this neurophysiological connections here.
I really like that description. And before we get too off track from your research study, let's bring this back. And can you describe for the listeners what the inclusion and exclusion criteria were when you implemented the study?
Yeah, sure. Well, we included women and men at the age of 18, between the age of 18 and 55 years, with unilateral acute and subacute lateral epicondylalgia humeri. The pain duration did not exceed 6 months. The diagnosis was just clinically, because for acute or subacute epicondylalgia, there's no imaging required. And then additionally, we wanted that gripping, resisted constriction of the wrist extensors, stretching the forearm extensors, or pain on the lateral epicondyle during palpation were required. We excluded patients with unclear clinical presentations or possible differential diagnoses, like, for example, cervical radioculopathy, posterolateral rotation instability, radiotunnel syndrome, or Plicker syndrome. And we also had some additional exclusion criteria that were predefined and retrieved anamnesically from patients' case histories, which were bilateral elbow pain, osteoporosis, tumor diseases, a history of operations on the elbow or thoracic spine, pregnancy, oral anticoagulation, really acute thoracic pain, or central pain medication.
And what were you using as your proxy measure for autonomic nervous system function?
Let me talk a little bit about the design. So We hypothesized that the thoracic spinal mobilizations in patients with tennis elbow would have a positive short-term effect on pain and sympathetic activity. And you mentioned the sympathetic activity, and we used skin conductance and skin temperature. Of course, we could have taken other measurements like heart rate variability, blood pressure, respiratory rate, skin temperature, electromyography, or blood cortisol levels. And I tried some. For example, I tried the heart rate variability, but it was just not practical. The heart rate variability was not measurable while the subjects were lying prone. We got so many artifacts. That's why we decided for the skin conductance and the skin temperature, because it's really easy to access. You attach the electrodes on the index finger, the middle finger, and on the ring finger on the affected sites. You can monitor it over the time. And the cool thing about skin conductance is that you get just the immediate reaction. So when you do the manual therapy, you just see it on your screen right away. And so far, skin conductance, as a recent review says, has the best evidence. But I'm aware that they're kind of notorious for the liability. So imagine when the patient is laying down and he's like drifting away with their thoughts. They might think about something that facilitates a stress reaction. You might see it on the skin conductance, or when the phone rings or the doorbell rings, so that might affect the measurement.
And this is a very specific question and maybe not fair, but you mentioned blood cortisol levels, and obviously blood makes things a little bit complicated, but did you consider at all measuring salivary cortisol levels?
We're thinking about it, but we don't have the laboratory to check it out,
Yeah, it's far more complicated from a physio standpoint than skin conductance. And as you mentioned, skin conductance just has by far the best evidence on these topics. The most studies at least, although as you correctly pointed out, the reliability isn't necessarily perfect.
Mm-hmm.
So you designed the study, you got your subjects to come in, you conducted the manual therapy on the axial skeleton in the thoracic region, and what were the findings once you were all done?
Yeah, right. So concerning the intervention, we did a grade 3 oscillation mobilization at the level of T5 with 2 hertz, and that's 120 pushes a minute. Our placebo intervention was a shame ultrasound. We decided to use a shame ultrasound as the placebo intervention, also directed to the thoracic spine, because the patient could not tell whether the device was turned on or turned off. We included 30 subjects, and they were all randomized, tested, and analyzed, and we had a dropout rate by 0%. To sum up, you can say the thoracic costovertebral mobilization at the level of T5 with the frequency of 2 Hz has an immediate increase in pain-free grip and sympathetic activity. Let me go through the parameters. There was no detectable change in the pain-free grip on the non-affected side, either in the treatment or in the placebo group. Concerning the pain-free grip on the affected side, within the treatment group, the pain-free grip significantly increased by 4.36 kilograms, and there was no significant change in the placebo group. Concerning the skin conductance, significantly increased by 48% in the intervention group, and there was no change detectable in the placebo group, and we had a significant difference between both groups. And the temperature significantly decreased by 0.8 degrees Celsius on the affected side after the treatment, and there was no change in the placebo group.
Were all of those findings things that you expected, or did something turn out in a way that you did not anticipate?
No, actually, we all expected this.
So speaking to those results, And you started to talk about this a little bit already, but I was hoping maybe we could dive in a little bit deeper. What mechanisms do you think contribute to these consistent changes that we see when orthopedic manual therapy is delivered to the axial skeleton, and then there's the subsequent autonomic nervous system changes?
Well, I guess you have to say the mechanisms remain unclear, but it's discussed. You have to understand that there's not only one mechanism of manual therapy that works. So you speak about multi-mechanisms that work together. We can say that because we can measure responses to manual therapy that are observed at the site of application, but we can also observe some things, responses at distal sites. So that's really an indication of the presence of a central mediating effect. Manual therapy just produces a chain of those neurophysiological effects, and one is this autonomic response, and we think, or many authors think that the autonomic responses are triggered by the dorsal periaqueductal gray, the limbic system, and the hypothalamus. But the periaqueductal gray is really in the focus because this one facilitates the autonomic response. So it's the important part of the body's own pain inhibitory system, and that's kind of cool because that's the body's own pain drug. So you have almost no adverse effects when you compare it to non-steroidal anti-rheumatic drugs, where you have adverse effects on kidney and stomach, and you don't have that with this own body pain drugs. The dorsal periaqueductal gray has a descending non-opioid analgesia. It has the sympathoexcitation with the skin conductance increase due to the sympathetic pseudomotor activation in the connection with the sweat production. You have the skin temperature decrease due to the vasoconstriction, and you have a decreased mechanical nociceptive stimuli, and it also facilitates movement.
I think that's a great response. Of course, in these situations, we always have to say that it's at least partially unclear. We of course have a lot of studies. At this point, I don't know how many, dozens or hundreds, that help give us, I think, good ideas on how to think about and contextualize a question like this. But it turns out the human body is just really darn complicated, and we haven't fully figured it out yet. That said, sometimes I need my patients to think I'm not crazy, right? And if I say something like, I'm gonna, push here in between your shoulder blades, and then, this temperature complaint, this pain complaint at a distant location might change, I need to have a way, of course, to try and explain that to them. And I don't know if this is fully correct or partially correct, and I'm not sure if it matters either way, but I always like to give them a twofold explanation. The first being mechanical, because I think it's really easy for them to understand. This thing here is stiff. I'm going to push on it and stretch it out. And then when it moves better, oftentimes you get a second response. And that's when I dive a little bit into the neurophysiological stuff that you started to mention. And of course, for an average patient, I'm going to provide that explanation in a digestible fashion. But I try to give them this two-sided point of view. One is mechanical, I can stretch it, you can stretch it. And one is just kind of like that internal magical black box of the human body, which is so complicated and amazing. We don't necessarily understand it fully, but we can observe how it responds. And then that can turn back around and inform us how much and how long we do the mechanical stretching for.
Yeah, that's true. I totally agree. And we have to get away from this biomechanical view because many therapists, or I believe that many therapists still think about this biomechanical view. They're not aware of the neurophysiological mechanisms, right? And you really have to explain it to the patients and also to the therapists, that they explain it to the patients. And so many patients come to my practice and they say, oh, this joint is not moving. Can you make it move again, please? But they're not aware of this neurophysiology that is going on in the body.
Yeah, and as I see it, it's really difficult to decouple the two, right? We're literally talking about a manual physiotherapy technique that you applied to T5. So that's the mechanical component, that's the stretching component. But if you're measuring something at a distant location, like skin conductance, grip strength, temperature, etc., then, there has to be some other way that these two areas are connected. And the most logical way, of course, is through the neurophysiological system.
Yeah, that's right. I can recommend the papers by Joel Bialowski. He tried to develop a comprehensive model about manuotherapy, about the mechanism of manuotherapy. And when you look at it, you see all this cascade that's going on. You start with the mechanical input, and then all those neurophysiological change that are starting, and one it affects everywhere in the body.
It's very interesting that you mentioned that. I believe that mechanism was discussed, or that paper was discussed in episode 38 of the podcast, which I think went live in April of 2020. So some of our readers, I assume some would be aware of the paper anyway. But if, folks aren't keeping up on research and they're just listening to the podcast, then they've probably also heard of that as well. And it's definitely the type of paper that our audience should check out, even if they have already done it. These are papers that are cram-packed full of information, and sometimes you can't just read them once and fully appreciate what they're trying to convey to you. So bringing things back to the clinic, and we've touched on this a little bit in a few different points. Can you try, from the clinical part of your experience, to explain why a research study such as this one that you have just completed and had published, why it's useful for everyday clinical practice, and maybe how you think clinicians should think of this content when they're evaluating and treating patients?
Well, yes, as you already said, many therapists treat the thoracic spine for upper extremity dysfunctions or lower extremity dysfunctions. And that can be explained due to this neurophysiological mechanisms. And I think it's kind of cool because you do not really have to treat the site of pain, because manuotherapy on the spine might be also very helpful. So imagine a patient where the pain level is so high that the patient doesn't tolerate any treatment of the site of pain. So you can use spinal manipulations to activate those body's own pain drugs, and then you can reduce the pain. That's pretty cool, and it seems that there's no significant difference between joint mobilizations applied to the spine and joint mobilizations applied to the extremities. That's Marcos et al. 2019. So you have the same effect on those body's own pain drugs, and that's pretty cool. But you always have to remember for a tennis elbow that you get the best effects in the treatment with a multimodal therapy program. So you should combine manuotherapies with the gold standard, which are stretching and eccentric strength training. You can reduce the pain with those manual techniques and increase the motor control with the dorsal periaxillary gray, and then do those eccentric strength trainings or the stretching trainings even better, So always use it in a combination.
I like that a lot. And if I could offer just a little bit of how I approach this clinically, and this is precisely what I teach to my patients, because I want them to not only understand what I'm doing so that they appreciate the process, but also because I want them to be able to implement the process on themselves, say, for example, from a home exercise program. And that is, similar to your study, but just in a clinic with less technical testing. After I have all of my identified impairments for this patient, I provide a treatment, and then I see if it helps or not. And then I provide another, and I do the same. And, let's just make up some numbers here and say, when this person comes in with lateral elbow pain, I get 30% of their symptoms to go away when I work on their axial skeleton. I get 20% to go away when I work on their tendon, so on and so forth down the line. Whatever gives me the best results is what I want to focus on. And I don't want to forget all these other things, the stretching, the exercise, the whatever it happens to be in addition to manual therapy, because they're also giving me benefit. And I'm not sure I'm ever, perfect when it comes to trying to create the hierarchy of this is most important and that's second. But as long as I'm always thinking about it and adjusting accordingly and moving in the right direction, which is my patient being pain-free, functional, etc., then I'm happy. And it gives the patient, when they start to understand that overall approach, it gives them a certain amount of comprehension and control, which I find to be very helpful from both a biopsychosocial standpoint and from a home program standpoint. So it's all about the process and the outcomes as far as I can tell.
That's true. And we were talking about the education, the patient education. You don't have to forget this, because we know that the patient copes better with his musculoskeletal disorders when he knows what's going on, when he knows about the musculoskeletal disorder and when he knows about the treatment and what he has to do. And then you get definitely better results than when you don't give them those education and those informations.
Very well said. And, hopefully physios all around the world are aware of that at this point. We're not just working on the periphery here. It's also cognitive, knowledge-based, emotional, affective, etc. There's a lot going on when we're working with a patient. So we're running out of time here, which makes me sad because this is perhaps my favorite topic in all of physiotherapy. I just want to ask you one final question, and that is, are you planning any subsequent studies on this or other topics?
Well, in my opinion, there are some interesting research questions, because now we only measure the short-term effects, and most of the literature only measures short-term effects. But as you said, you want the best outcome for the patients, and so we really need studies about the long-term effects. And we need to know if those changes in sympathetic activity are really clinically relevant. And also, as the review said, we just need other musculoskeletal disorders where you can, as symptomatic populations, to check if there's the same mechanism going on. Yeah, I really want to do some further research, but it's kind of hard to do research here in manual-therapy in Austria, because on the University of Advanced Studies, there's almost no research done. The health industry is focused on drugs and operations. Well, it's getting better over time, but I guess it's everywhere in the world. It's still hard to find some funding,
Yeah, there's no doubt about that at all. Unfortunately, I think historically speaking, and when I say that, I mean maybe approximately the last century, physiotherapy research has been slowly ramping up, but it's definitely taken a backseat in terms of funding, etc., from a more medical, surgical, pharmacological approach to research. And, I think that's improving over time. And I look forward to the day when some wise, forward-thinking organization hands you $1 million grant to study this in any way that you wish.
That would be awesome, yeah.
Well, when that happens, you let me know, and we'll have you back on the podcast to talk about your forthcoming studies. Until then, I would just like to say it's been a distinct pleasure to have you on the podcast, and I hope that you stay safe and take care.
Yeah, thank you very much, Steve. I really enjoyed talking to you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.